morning, everyone. Thank you very much for inviting me to speak to you at Grand Rounds this morning. I'm going to be talking about some updates in the world of glioma diagnosis. So these are papers that have been published in the last year that impact how we're diagnosing gliomas. So the papers I'll be discussing come from a group called CIMPACT-NOW, which stands for the Consortium to Inform Molecular and Practical Approaches to CNS Tumor Taxonomy, not official WHO. And this is a group of experts, many of whom actually helped to write the WHO. And they are creating timely updates to impact the way we diagnose tumors. And if you can see on the right side of the screen, the WHO classification of tumors, which is our dictionary of tumors. The first edition came out in 1979, and the next one was 14 years later. Another 14 years to get to the third edition, and then 9 years to get to the fourth edition, which is now 2 years old. And the world of, especially molecular diagnostics, has been advancing much faster than that. So the CIMPACT group is trying to provide much more timely, rapid updates on how we can accurately diagnose and define CNS tumors. So with that in mind, I'll be talking about 3 different cases that describe the 3 different updates that CIMPACT has published this year. So the first case.
Good morning. This is the case of a 27-year-old who presented with 3 months of progressive left facial numbness, left facial droop, left tongue deviation, decreased hearing on the left side, as well as some subtle weakness on the right hemi-body. MRI, which we'll discuss in a moment, demonstrated a large, subtly enhancing posterior fossa tumor. He came to surgery for an open biopsy to obtain definitive pathology to perform adjuvant therapy.
All right, first image here is a coronal T2 flare. In the posterior fossa, there's this infiltrated expansile hyperintense mass. It's involving the brainstem and left cerebellar hemisphere. There's superior extension up to the thalamus and inferior extension towards the cervicomedullary junction. Axial T2 flare, there's the mass, you can see it's expansile. And it faces the fourth ventricle as it extends through the middle cerebellar peduncle, crosses the midline in the pons. On the post-contrast sagittal T1, you can see that there is a low intrinsic T1 signal, but of note, there's really no internal tumor enhancement. There are small areas of meningeal enhancement as we can see along the dorsal surface of the clivus.
So there was a biopsy performed on this patient, and then we had a frozen section to assess the adequacy of the biopsy. And this is actually a really lovely looking frozen section for us. And you can see on the left is a lower magnification view, and on the right a higher magnification view. And in both you can see that there's a fair number of cells, and there's a lot of very fibrillary eosinophilic cytoplasm. And in particular, that makes us think that there are glial cells present. And on the right side, you can see some relatively enlarged cells with eosinophilic cytoplasm and multiple nuclei, enlarged nuclei. So these are very... So these are highly atypical cells and would be leading us to think about a glial neoplasm. So for the frozen section diagnosis, we said there is diagnostic tissue received, and we favor glioma based on those findings. And then moving to the permanent section, we have some very hypercellular brain tissue. And then moving in closer to actually look at the tissue, this corresponds very nicely to the frozen section in that there are these large atypical cells that have abundant eosinophilic cytoplasm, and they have multiple nuclei. In addition, in the background, you can see a lot of cells that have relatively enlarged nuclei with irregular shapes. And then There are multiple mitoses in this high-power field. We could find up to 10 mitoses and 10 high-power fields. So it's a mitotically active gliomeoplasm. And there was no definite necrosis and no microvascular proliferation. Given the dense cellularity of the tumor and the location, we weren't able to definitively say that it was a diffuse or infiltrating process on the H&E. So we used a neurofilament stain, which highlights background axons, and that demonstrates that the tumor cells are actually infiltrating and growing into pre-existing structures. So from this stain, we can say that it's definitely diffuse. As I mentioned before, histologically, it looks like a glioma. We have a GFAP stain, which is consistent with that as a glioma. Other workup we did includes the IDH R132H immunohistochemical stain, which is negative, and a Ki67, which is elevated up to about 40%, which corresponds to that high mitotic count. In addition, given the midline location of this tumor, we did staining for histone 3 K27M mutation. And it's a little, it looks better there than my screen. But you can see that there's nuclear staining in a large subset of the nuclei in there. Because it wasn't staining all the nuclei in the hypercellular region, we also did the H3 K27 trimethylated immunohistochemical stain, and that should stain wild-type cells. So the fact that there are negative neoplastic cells is further consistent that there's an H3 K27M mutation. So the diagnosis on this case was diffuse midline glioma, H3 K27M mutant, WHO grade 4. And this was the topic of the CIMPACT equals update as a clarification for when you should use the diagnosis diffuse midline glioma, H3 K27M mutant.
Is this, can you just, I mean, for the pediatric neurosurgeons, we always think of DPIGs, these diffuse intrinsic pontine gliomas. Do they have I mean, I know there's a spectrum of disease in the pediatric population. Do they have H3 K27M mutations? Do we know?
A large percentage of the pediatric DIPGs have the H3 K27M mutation.
Okay.
So they would receive the same diagnosis.
Okay. So this is like a pediatric.
Yeah. And I actually, the next two slides have a little more information about the tumor process.
Okay. Thank you.
So the H3 K27M mutation is most common, like we said, in these diffuse brainstem tumors, but the H3 K27M mutation has also been found in additional CNS tumors. And those would include ependymoma, pilocytic, astrocytoma, and ganglioglioma. So just finding the mutation isn't enough to give you the diagnosis of an H3 K27M mutant tumor. So their H3 K27M mutation can be associated with different histological findings. And in these other types of tumors, the patients survive much longer than in the diffuse midline gliomas. So because of that, it's not just the mutation that defines the diagnosis, but it's the mutation in the context of a diffuse midline glioma. So the CIMPACT actual update was to reserve this diagnosis for tumors that actually meet all these criteria, for tumors that really are diffuse or infiltrating, that are midline, thalamus, brainstem, spinal cord, and that are gliomas. They usually have an astrocytic looking morphology, which this case did. They could have the K27M mutation in histone 3 or 1, and that can be assessed by immunohistochemistry. And the presence or absence of mitotic activity, necrosis, and microvascular proliferation doesn't really matter for grading. They're always a WHO grade 4 because of the poor clinical outcomes. So the diagnosis of diffuse midline glioma H3 K27M mutant was part of the 2016 WHO. So it's something that we've been using for about 2 years. And that does occur most commonly in the pediatric population rather than in adults. Partly children get a lot more of these diffuse brainstem neoplasms than adults do. And the imaging findings, as far as I can tell, are non-specific for the mutation, they can tell you that it's a diffuse midline tumor. And the histology actually varies from case to case. So about 10% of the cases we would usually call a low-grade, something that looks like a diffuse astrocytoma but doesn't have a lot of mitotic activity or necrosis or microvascular proliferation. And about a quarter of cases have the increased mitotic activity and could be a grade 3. But all of the cases that have this mutation have a really poor prognosis, so it's really counted as a grade 4. In addition to the K27M mutation, there's a lot of other frequent genetic changes. So about half of these tumors will also have a TP53 mutation. And then moving down in frequency, many of them will also have a PDGFR mutation or amplification, a mutation in cyclin-dependent kinases, and then sometimes ATRX also. And P53 and ATRX we commonly check for in the adult diffuse gliomas. The details of how K27M acts as an oncogenic trigger are still being investigated, but it turns out that even in a tumor that's H3 K27M mutated, that's only a subset of histones that have that mutation, and a fair number of other histones retain the ability to be trimethylated. So one theory is that the methylating complex actually gets sequestered by K27M because it binds that more tightly than the wild type version, and then it's unable to move throughout the cell and actually continue methylating the histones. And of note, the K27M mutation is fairly specific, and it's something that can be antigenic, so you can raise antibodies to that. So we can use those for immunohistochemistry to diagnose the tumor. But it also means that there's potential to develop a vaccine and therapies in these cases because you can target the neoplastic cells. And as we said, the majority of H3 K27M mutant tumors are found in children, but here's a review of a single institution study that reviewed 25 diffuse brainstem tumors in adults, and they found that about a quarter of them have the H3 K27M mutation. And the patients with this mutation versus with the histone wild type version had similar ages. As I said earlier, there's a significant subset of these H3 K27M mutants that have a relatively low-grade histology. So 2 out of 7 would not have been called a grade 3 or a grade 4 based only on the histology, but they do become a grade 4 based on the molecular data. And then they found, as you can see in the Kaplan-Meier curve, that the patients with the H3 K27M mutation have a much worse survival compared to the H3 wild type tumors. So that's the first case and the first in CIMPACT update, which tells us that the role of molecular data in diagnosing a grade 4 lesion. So the next case, I think, expands on that as far as how we can use molecular data to diagnose tumors.
Kathryn, can I ask a question? So
yes.
Essentially, the CIMPACT group has created discrepancies with WHO, and I'm just curious whether these discrepancies are accepted outside of working Workup, number one. And number two, I'm curious if anyone's looked at treatment response, because we call these, I know the other cases too, but we call these grade 4s, and I'm wondering if they respond to the treatments that they usually respond to, or if these are something entirely different. So 2 parts.
Okay. So I see the CIMPACT group not as creating discrepancies, but as clarifying things that were confusing in the WHO. So it's creating more categories, but it's giving people better definitions for what actually makes the categories work and what's important.
But I mean, that would have been called a grade 3 without the H3 mutation. So it is a discrepancy. It may be better, it may be more accurate, but it's still different. And since most of the world uses WHO, including the NCCN usually, I'm just curious if everyone's getting on board.
So the H3K27M mutation, because it's been studied, especially in the pediatric populations, is a WHO classification. right now. So their update was more of a clarification. Most of the brain tumor studies in adults have been retrospective, so there's not a good way to really clarify, I think, what the effect of the treatment is in the patient population, because it's really circular in these retrospective studies as far as you call it a grade 4, and then they get the treatment appropriate for that, and then you look at their outcomes. So we don't really have great data to say that treating them as a grade 4 improves their outcome. What we have is that they have relatively short survival times, even with treatment. I think outside of North America, we've exceeded my knowledge.
Yeah, for the CIMPACT, they have people from all over the country, Europe and Asia, departments, so it's accepted widely the CIMPACT with the WHO outside of North America.
You were saying it?
Okay, so the second case.
So this is a 70-year-old left-handed male who experienced approximately 3 to 4 weeks of vertigo and episodes of lightheadedness that led to workup by his PCP, got an MRI brain that demonstrated a mass. An evaluation is awake, alert, oriented to person, place, and time. He was intact in terms of motor strength and visual fields. And after doing a WADA test to determine language sightedness, he was brought to the OR by Dr. Scherpelz.
Okay, axial T2 showing a right temporal diffuse cortical and subcortical signal abnormality. On a coronal T2, you can see asymmetric narrowing, mass effect, asymmetric narrowing of the temporal horn of the right lateral ventricle. And on coronal T1, the lesion is less conspicuous and, like the prior case, does not demonstrate any appreciable tumor enhancement, and really not much evidence of any abnormal meningeal enhancement either.
So this tumor was resected, and I'm showing here an image of the cortex, and you can see at the very corner we have a leptomeningeal surface, where cortex moving into white matter towards that corner. And the cortex looks a little bit busy here. There's somewhat more cells than we would expect. And then moving into higher power, we see that there's some atypical cells present. In one corner, there's a neuron with a very large nucleus. And then most of the rest of the field is atypical glial cells. So I've circled a few here. They have particularly large nuclei. They're oddly shaped. The nucleoli are standing out. And then the lesion is also mitotically active, so up to 5 mitoses and 10 high-power fields. And there was no microvascular proliferation or necrosis. So based on our usual histology, we've seen that it's diffuse. It looks like an astrocytoma, and it's mitotically active. So we would typically be calling this WHO grade 3. And then we did additional workup. So the IDH immunohistochemical stain is negative. Ka67 is much higher than normal brain tissue. I was at up to 4%. And then ATRX shows nuclear staining, it's retained. P53 shows rare positive nuclei, so no evidence of a P53 mutation based on this. And we did molecular testing to look via FISH at chromosome 1p and 19q, which are retained. We saw gain of chromosome 7, but without amplification of EGFR. Retention of chromosome 10 without a P10 deletion. And then by sequencing, because of the negative immunohistochemical stain and the apparent low-grade histology of the tumor, we sequenced and found no IDH1 or 2 mutation. And we also searched for TERT promoter mutation and found a C228T mutation, which is the activating of the TERT protein. So this particular set of molecular testing is largely determined by the next CIMPACT paper. So these molecular results led to a very lengthy integrated diagnosis of diffuse astrocytic glioma, IDH wild type, with molecular features of glioblastoma WHO grade 4. And the molecular features of glioblastoma WHO grade 4 in this case are the TERT promoter mutation. And this is classified as a WHO grade 4, even though histologically we would call it an anaplastic astrocytoma. So the CIMPACT-NOW update paper that discusses this was focused on how to use molecular information to better define how diffuse astrocytomas will behave. So there's been data that show that some diffuse astrocytomas are IDH wild type, but there are other mutations within the lesion that can determine that they'll have more aggressive behavior. And you've already seen the H3K27M mutation as an example, where that mutation really sets those tumors apart in their behavior from other tumors. But there are other mutations like the H3G34 mutation, where these are diffuse gliomas that also behave aggressively, and they don't currently have a separate classification. So the CIMPACT group is trying to sort through the data and determine which cases there's really enough evidence that a diffuse astrocytoma will behave aggressively. And in addition to which mutations are involved, they wanted to think about which mutations are relatively specific in diffuse gliomas, because we're not only making a diagnosis that looks at a diffuse glioma or diffuse astrocytoma for grade 2 versus 3 versus 4, but based on the histology, we may be considering other entities like a glioneuronal tumor or pleomorphic xanthoastrocytoma. And can one of these mutations be found in these other entities, or is it relatively specific for the diffuse astrocytoma? So by reviewing the literature and trying to choose only mutations for which there were multiple solid studies, they found that the most reasonable choices that define aggressive behavior in a diffuse astrocytoma that's IDH wild type are EGFR amplification, combined gain of chromosome 7 and loss of chromosome 10, and the TERT promoter mutation. So any one of those mutations in an IDH wild type diffuse astrocytoma warrants this new, very long diagnosis of diffuse astrocytic glioma, IDH wild type, with molecular features of glioblastoma, WHO grade 4. So what I'm going to do next is look at a small amount of the data that support why these particular molecular changes were selected. So EGFR amplification is relatively common to be found in IDH wild-type glioblastomas, in about a third of them. And EGFR amplification can also be found in a subset of low-grade diffuse gliomas. And the amplification of EGFR was found to be relatively specific, so that it occurs largely in these diffuse gliomas. And they note that amplification and not just trisomy is necessary to create this category. So it's EGFR amplification. And you can't assess for that with immunohistochemical stains accurately. You really need to have FISH or sequencing data to support that. And the graph here comes from a Chinese group which looked at about 120 diffuse gliomas and found the EGFR amplified ones have a much lower survival than EGFR non-amplified tumors. The gain of chromosome 7 and loss of chromosome 10 is another molecular finding that's relatively common in IDH wild-type glioblastomas and also in the lower grade IDH wild-type gliomas. And it's also relatively specific as far as occurring in the diffuse gliomas. And they've noted that 7 gain 10 loss often co-occurs with TERT promoter mutation. So if you have both of those, it's not known whether that really behaves even worse than having only one. And then this graph this was a group that was looking at a large number, over 70 different gliomas, and splitting them up by different gene expression and molecular categories. So these are other categories, but the red line here shows gain of 7, loss of 10, versus a standard IDH wild type glioblastoma outcome. So much more similar compared to the glioblastoma, and then less similar compared to other gene expression profiles within IDH wild type diffuse gliomas. The TERT promoter mutation can be seen in, again, a large number of IDH wild type astrocytomas and in IDH wild type glioblastomas. But it's not as specific for these entities, and that you could also see it in dimorphic xanthoastrocytomas or gangliogliomas, ependymomas, oligodendrogliomas, and medulloblastomas. And when you look at the survival curves for patients with the diffuse, otherwise low-grade glioma with a TERT promoter mutation versus TERT promoter wild type, you can see that they do have a significantly shorter survival. And the CIMPACT paper focused on these three as these having the most evidence to support that. So having multiple papers in each one with relatively large cohorts. But they note, of course, that there's more molecular information out there, and we may need to update this list. So things that may be on the horizon would be partial loss of 7 and 10, particularly looking at 7q and 10q, using different methylation grouping strategies to assess how tumors will behave, whether it's a better prognosis or a worse prognosis, or using a MIB-L mutation to select which patients will have better outcomes. And of note, I think as I mentioned earlier, these data are largely derived from retrospective studies. They're from adults, which is good for this population, and they're usually supratentorial tumors. There isn't as much data as far as the prospective studies, especially like this most recent paper came out this fall, so it's been 2 or 3 months. So there hasn't been time to develop good prospective trials to see how these matter and what kinds of treatment might actually be applicable to which specific types of tumor. So based on that, this is a representation of how we approach a diffuse glioma workup at this point. So the first thing pathologists really like to do is to review the histology and confirm, is it a diffuse glioma, and is there anything else we're worried about? If it's a definite grade 4 glioma based with necrosis and the microvascular proliferation, then our next steps are to do immunohistochemical staining for IDH mutation, and that will get further sequencing if the stain is negative and the patient is relatively young, less than 55. And then we'll do MGMT send-out testing on every patient. If the tumor is not obviously a grade 4, it's a lower grade tumor, then we have a more extensive workup. And we would do 1p19q FISH, where if that's co-deleted, we think about oligodendrogliomas. We also check for EGFR amplification, which is present on chromosome 7, and then p10 deletion, which is present on chromosome 10. So we can look at EGFR amplification and then the gain of 7, loss of 10 via FISH. And that way, every grade 2 or 3 tumor will get IDH immunohistochemical testing, and followed by sequencing if the IHC is negative. We'll check for p53 and ATRX mutations via IHC. Check for Ki67 to confirm that that is concordant with our mitotic count that we're seeing. We've added the TERT promoter sequencing into this panel, and then MGMT testing. And then in addition to these basic tests, we will get additional testing as warranted by other histologic findings of the tumor site. So getting an H3K27M stain depends on where the tumor is. And then depending on what the tumor looks like and what the differential diagnosis is, histologically we add other stains. The amount of tissue that's required for each of these tests is different, and then the length of time that the tests take to get results is also different. So immunohistochemistry takes 1 slide per stain, and we have a turnaround time of about 1 day, so it's relatively fast. The FISH testing usually also takes 1 to 2 slides per fish marker that you're evaluating, and that takes 3 to 5 business days to come back. Sequencing takes 10 slides that are double thickness, so it takes quite a lot more tissue compared to the IHC, and that takes multiple weeks to come back. And then the send out takes 5 slides, and it takes a couple of weeks to come back. So what we're working on is balancing the best way to use the tissue, especially in a biopsy where there's relatively small amounts, to get the answer, and to get the answer quickly and report it to you quickly. So in most cases, that means we're starting with immunohistochemistry and with fish, since those use smaller amounts of tissue, and then moving on to the sequencing after a couple days when we verify that the sequencing is necessary based on the immunohistochemistry, based on the fish results. Do we actually need TERT promoter sequencing, or can we say that it's already EGFR amplified and we don't need to take that next step?
Dirk, can you give us just a ballpark figure of the amount of tissue? Because, you know, I mean, I always think of PCR, you don't need much tissue and you're good and you can get these things, but these are different hits and different tests, right? So you have to take them different places, it looks like.
Yeah, it's, and, you know, TJ can respond to this as well, but, you know, as to the absolute amount of tissue, you know, it's hard to say. We try. I mean, in some of these cases, there's not much, you know, stereotypic biopsy. We work really hard at the outset when we get these cases now more elaborate. We try to get everything cut at the same time, so we're not wasting any tissue from the blocks. Certainly, you know, something like a half a cubic centimeter or something is probably sufficient for most things, or you know, multiple cores on a stereotactic biopsy or something like that would probably be sufficient. But to be honest, a lot of it depends on the quality of the tissue, not the amount.
Okay.
And so if you're in something that has necrosis, or there's a lot of normal brain and there's not very many infiltrating cells, then it's going to change how effective your testing is. And so it's a really important point. And to extend upon that, right, I mean, and kind of to Dan's point, you know, when we have the whole resection of a big tumor, there's, you know, what we can do is basically unlimited. Right? And so we can see the microvascular proliferation, we can see the necrosis that's going to really help put this into a grading bin. But when you have a biopsy, and we're actually really fortunate here where you guys are really good at getting into the sort of the heart of the tumor without getting us just necrosis, and we appreciate that. But that's not always the case. And so if you're in the edge, right, where it's infiltrating, but you're not in the part that has the high-grade features, these new molecular tests are really helpful in sort of helping us categorize by grade without having the whole thing to evaluate. And so I don't think of it as being contradictory to the, you know, existing grading schemes, but just as a way to sort of help put this into a category when we may not have the whole thing to examine. And even if we have the whole thing, right, we can't put every piece of tissue on a slide, right? We get a slide out of a block that's 3 or 4 millimeters thick. That's 5 microns of a couple millimeters, and so it's a real problem. So I know we always ask, and I know you guys get tired of it, but you know, the more tissue you can give us, obviously, safely, is appreciated. And now more than ever, right, we can do an IHC and have 10 cells and make a diagnosis in some cases. For these molecular tests, we can't do that, right? We need an amount, and I don't know what the weight is. It's very
No, but this is helpful from a practical standpoint. You know, obviously there's some stereo biopsies you just can't get more because the lesion isn't big enough where it's too deep. But some of the tissue, I mean, we can just keep getting cores, you know, instead of getting 2 cores, we can get 5, instead of getting 5. If we're in the middle of the tumor, we can get 10. This is helpful because it's just not one kit and one piece of tissue. It sounds like you have to run a lot of different pieces. This is totally different, and it's of practical importance to us.
Yeah, I mean, ultimately, it would be nice if we could take one piece of tissue and process it in a way that could be used for all of these tests.
Yeah, got it.
Right? But right now, we have different send-outs for different things, and it's a bit of a Wild West right now, but I mean, we'll get there.
Dirk, how far are we from automated evaluation of tissue assisted with AI in pathology. I mean, I know that there are a lot of efforts in that direction. What about neuropathology in particular?
So I am not, so certainly we don't have any efforts here from a neuropath perspective that I'm aware of. I don't know nationally or internationally how much AI is being used as far as neuropath. Neuropath's a little bit, we have a big effort here for
No, but general pathology, there are things.
Absolutely.
Yeah. So that's why I'm asking, like, simple things like counting mitoses and various things, you know, which you, obviously you guys are struggling with right now. Those are things that, it's not a replacement,
No,
but
I
an
know.
assistant type of thing.
So there are some technologies that are relatively easy to access, right? So the breast folks have algorithms to try to estimate mitotic activity or proliferative activity on the stain. That's technology that's very straightforward. We have all the scanning capability now and the image analytic capabilities theoretically to do this. We haven't put effort into that, and as yet, and I defer to my colleagues if they can add to this, but I don't know how much that actually adds to our diagnostic capability from a perspective of these things, but if it does, certainly we would do that.
But the reason I asked that question is that you raise the problem that when you have large amounts of tissue, you can only sample small volumes. But if you had, you know, something like an AI, it can sample or it can look through large amounts of tissue and then give you certain information that can focus you on certain areas or whatever.
Yeah.
So basically to use such a thing as an assistant to improve your diagnosis, it may become more important if we have modes of therapy that become available that are based on antibodies to specific antigens. You know, I don't know, CAR T-cell therapy, whatever it is. So.
Oh, I agree. And there are actually some really interesting algorithms out there to detect mitotic figures, which is not nearly as trivial as detecting Ki67 positive cells. And so, so I don't think we have any research efforts here that I know of that are really directed at neuropathology, but certainly we try to keep up with the latest recommendations and guidelines as far as anything that's going to improve patient care. So if something came down the pipe and said, you know, if you can apply this approach to these brain tumors and it's going to improve your diagnostic accuracy, that would be top of the list to do. And then I would defer to Gordon or PJ or anybody that wants to comment on that. Ian?
I don't know anybody using it in a clinical setting out in this country, right? There are people doing that thing with mitoses and Ki67, like you said, and that reduces the amount of time that the individual pathologist will spend on the case, so it saves them time. But practically, it takes even longer, right? Because we have to ship off the slides, they have to be scanned, we have to get them back. So it can add like a day or two just to get everything scanned, and so the case would be signed out, take even longer. As far as AI here, I am working with some people in the engineering department looking at trying to define minimal residual or tumor burden that might be useful intraoperatively for like the amount of tumor left behind at the margins of these things. So there's some AI interest here, but it's still pretty nascent and not for prime time yet.
Question. Is there any differential presence or absence of any of these features within the tumor based on its geography? For example, enhancing versus non-enhancing, adjacent to necrosis, areas of microvascular proliferation. Is there any difference there?
As far as where we would actually do the testing, for instance?
Yeah.
We have not been targeting areas of tumor that are next to necrosis. I would say what we usually do is actually try to find a large bulk of viable tumor cells.
How about enhancing versus non-enhancing?
So there aren't very many situations where we look at the tissue and we can say this is from an enhancing region of the tumor and this is non-enhancing unless we have a biopsy that was specifically of an enhancing area. Is that?
It was my impression that that's what the Allen project was doing. Does anybody know?
Yeah. So right. So it wasn't exactly the enhancing components, right? So the challenge that we have, I mean, the way the surgeries are done, we rarely get these things in big pieces that we can map from a perspective of correlating with an imaging, right? We just can't do that, and so we have to use surrogates. So the Allen Atlas focused on different components of a brain tumor that are related to enhancement, so microvascular proliferation, necrosis, that sort of thing, and then they basically use AI, machine learning, to identify these regions in the different tumors, and then they did in situ hybridization and molecular testing across these different regions. In our case, we usually try to pick. So for the other part of your question that I think you might have been getting at would be heterogeneity. What is the heterogeneity of a tumor with respect to these mutations? And there's certainly a clonal population within these tumors, and so these mutations can accumulate, and so there's probably areas that have some, but not all. We usually try to focus on areas that have less normal tissue and more viable cancer, but we don't do this in multiple blocks. We don't really like, we pick an ideal section that has some the more malignant features, I guess I would say. So if we don't want to get necrosis, because that's going to be a problem, but somewhere that's hypercellular with the diagnostic features, the neoplasm that we think is going to be sufficient for molecular testing, and focus on that. But we have to bill separately for each time we do this, and so we really are limited to just one sample of the tumor right now. From a clinical perspective, from a research perspective, I'm sure there's lots of efforts. Again, I defer to my colleagues who know more about this than I do. I'm sure there's lots of efforts to characterize heterogeneity in these cancers with respect to all these different molecular features. But practically, it's a little bit difficult because we can't really sample it with respect to especially imaging. Right? You just can't encode the pathology back to the imaging because of the way these things come out.
Corollary to that question is that, as you know, there is a technology called the simulated Raman microscopy. Now the technique is commercially available. I don't know if you know about that, but at least in our recent meeting, I've seen the commercial machine. I think they're only marketing it for as a replacement for the frozen section, but not for intraoperative use. But it is possible to actually do it in vivo, intraoperative microscopy. Can that be used to guide the surgeon in doing the? Obviously, it won't be possible for deep lesions, but for surface things, can that be used to guide the surgeon as to where to, take the biopsies and stuff?
Right. I mean, I totally defer to Gordon on this. She's the expert on this, so you can answer that.
Well, I think there are different populations in Raman imaging. Basically, it's just how to identify H&E histology. So the idea is just to use to basically maybe put on side intraoperative consultation frozen. So because that's simulated H&E, which is relatively close and just looks relatively similar to permanent sections. So in the OR, basically you still need pathologists to get information because it's not that you can identify morphology. You have to be skilled, as a neurosurgeon. So, but another thing, you can see as you touch the probe, you can get biochemical information, and you can say, okay, we have neoplasm or it's a brain. So it could be helpful at some point. But I think that this is just beginning, and we have to work on this more.
For those who don't know, there's a neurosurgeon by the name of Olinger. He took a year off from MGH and they worked on this. Do you know him? Or MLG developed into a company which is now making these machines. And
we use it in the OR, but it's a combination with neuropathology.
The other technology that I just want to bring up, which is being used sort of in a cutting edge way here from a general pathology perspective, particularly for prostate, is light sheet microscopy to really get through the tissue, right? As you say, we're limited to the surface of a tissue slab that we look at, and there are new techniques to clear tissue which have been developed from a basic science perspective that can be used to map, basically evaluate tissue in a three-dimensional fashion through a block that are being used to try to help pathologists see more of the tissue. There's no applications for that in the brain at this point from a cancer perspective, but I would expect that'll be coming quite shortly.
But with Rana spectroscopy at the moment, we are not able to identify molecular profiles of any tumor, brain tumor, and overall, just brain tumors.
But if an area looks more aggressive, then the neurosurgeon can take a biopsy of that particular region for further studies.
Well, if this basically you can identify, you say, okay, this is a non-neoplastic area. But you're not able to, this is more so, or this is not, it's very hard to identify.
You have one more case, right?
Before you go on, Kathryn, sorry to interrupt. Can you just, Dr. Ellenbogen's question. So we do a stereotactic biopsy, and you don't have enough tissue to do all this stuff. Can you just quickly go over how you prioritize this? Because I think it's going to lead. I mean, it does obviously already lead to treatment conundrums. I mean, because there's a diagnostic problem. So maybe you could just quickly say how you do this. We get 3 cores and there's a lot of blood and we quit.
Yeah.
And so, what are you going to do with the tissue? What are you not going to do with the tissue?
So there's one more case. I was going to abbreviate that into just 2 slides. So as far as what we prioritize, I think in a diffuse glioma where we already know that it is a diffuse glioma, getting the IDH mutation status is especially important. So getting that immunohistochemical stain, and then if histologically it could be in the oligodendroglioma category, the 1p19q fish, that would be like 3 slides worth of testing right there. That's not very much. It's usually not a problem to go beyond that and get, say, 5 more slides for immunohistochemistry and fish testing. And the really big difference is when you need sequencing, because that is the kind of thing where that will use up a very large percentage of the block. So we usually try to start with the tests that use less tissue and take less time, so we sort of feel out the options and then move on to sequencing after we've gotten the fish results.
To expand on that, it's pretty straightforward from the big picture. We can do a lot histologically. We can get it quite a ways, right? We can't diagnose. I mean, people might disagree with me, but we really can't diagnose an infiltrating glioma by just sequencing it, right? I mean, that's not totally true. You can infer an infiltrating glioma by the molecular profile, but that's not an exact science by any means. And so we have to get it into some category, and we can do that with the histology. And we don't need very much tissue for the histology, and so we have to start with the histology. We prioritize it for the mutations that really drive prognosis and treatment and diagnosis with versus IDH and some of these others. And then if we don't have enough for sequencing, we don't have enough for sequencing, right? And then we're sort of left with a bit of a conundrum, which the CIMPACT people have addressed a little bit, and certainly the WHO tried to address. But we're in a transition, right? I mean, ultimately, we're still gonna need morphology probably, but molecular is going to drive all of this, right? And so ultimately, I expect we'll just take an H&E and then grind it up and send it off, or do it in our lab and develop the diagnosis from that perspective. And so we're sort of maneuvering as the new regulations and new recommendations come out. But right now it's histology first, and then we try to preserve the tissue as much as we can. Sometimes we can't. Sometimes there's not enough.
All right, so I'll do just an abbreviated description of the 3rd case, in that I think it has bearing on that last discussion. Just to give you the background, this was a
I can give a little background. So, 59-year-old right-handed male with a history of esthesioneuroblastoma was treated in 1985 with surgical resection and radiation. He was followed with scans after treatment, found to have no recurrence. But approximately 2 weeks prior to presentation, he started to develop headaches, and wife noted that he was becoming more confused over time. Difficulty with tasks normally would have been easy for him. And so he presented to the emergency department, where he was found to have just mild nausea, vomiting, but significant confusion. Notably, he was alert and oriented ×4. Visual fields were full in his right eye. His left eye was blind as a result of the esthesio and the radiation he had previously. And no printer drift, full strength fuse, bilateral upper and lower extremities. He was counseled basically to go through a biopsy for this lesion. Under that with Dr. Scherpelz.
Okay, real quickly here, we have an axial flare showing a right frontal heterogeneous hyperintense lesion centered in the basal ganglia abutting the thalamus. On T2, we see most of the solid portion of the tumor is T2 bright, while there's some cystic regions that are T2 light bulb bright. On the axial pre and post, the tumor is T1 hypointense and demonstrates fairly confluent homogeneous enhancement other than those cystic T2 bright lesions we saw on the prior slide. Axial SWI and coronal non-contrast CT shows very little evidence of mineralization demonstrated by blooming artifact on the SWI and hyperdensity on the CT.
So on the biopsy, I trust that you can see that this is really hypercellular tissue. And the cells have the enlarged, atypically hyperchromatic nuclei that we usually see in glial neoplasms. And moving along, neurofilament in the background shows that it's a diffuse lesion. GFAP is consistent with glioma. The IDH stain for mutation is negative, and Ki67 is elevated, which goes along with elevated mitotic activity. We didn't see any definite necrosis or microvascular proliferation in this lesion. Because of the apparent, we would have called it a grade 3 based solely on the histology. We did FISH for 1p19q codeletion, and because of the negative IDH immunohistochemical staining, we sent it for sequencing and had insufficient yield of DNA to determine whether it was an IDH mutant by sequencing, and the block was exhausted at that point. So the teaching point for this case was really the terminology that we use to discuss these lesions where there's not a definite diagnosis that we can make histologically. So in this case, we called it a diffuse glioma NOS, or not otherwise specified, and it's at least a WHO grade 3 based on the histologic features. 1p and 19q were co-deleted by fluorescence in situ hybridization. But we can't definitively say that IDH is or is not mutated. I think for general reference, I wanted to share that 1p and 19q codeletions are part of the definition of oligodendroglioma, but having a 1p19q codeletion does not make something an oligodendroglioma, in that you have to have an IDH mutation as well, which is usually the R132H, and also the 1p19q codeletion. Exactly what you're measuring depends on the method that you're using to measure it. So the FISH testing is reliable for the most part, but it can be problematic when the FISH probe is binding to a part of the chromosome where there is a deletion, but the entire arm of the chromosome is not deleted. And the 1p19q codeletion of oligodendroglioma is meant to include the entire 1p and 19q arms. So the graphic at the bottom shows, for example, a partial loss of 1p and then a partial loss of 19q that were found in a glioblastoma case. And this was called 1p19q codeletion based on FISH, but molecularly didn't actually meet the criteria that we mean there. And the the published CIMPACT paper that discusses this area really defines what you mean by NOS, not otherwise specified, versus not elsewhere classified. And this is different from other areas of medicine in that NOS is now used to describe testing which would be required to reach a specific diagnosis, which either cannot be performed because you don't have tissue, either will not be performed, for instance, if the patient has decided to move on to palliative care and not seek any treatment, so that testing results wouldn't matter, or if the testing is performed but it can't be interpreted or it's unsatisfactory in some results. And then NEC, not elsewhere classified, is used to describe a tumor where the molecular data and histologic data are somewhat different from each other. The genetic data is important, but it doesn't actually make the diagnosis. So the idea is that the NEC category will actually decrease over time as the WHO gets updated. And examples of these cases, something that's NOS would be an example like this case where we had IDH1 wild type by immunohistochemistry, but we were unable to do sequencing to confirm whether a different mutation was present. Whereas a diffuse glioma that has a BRAF V600E mutation would be considered not elsewhere classified. It's a tumor that has a mutation that's of interest, but it's not really, the mutation is not part of the diagnosis itself. So in summary, the things that we've talked about today are that the integrated neuropathologic diagnosis is incorporating both histologic and molecular features. And the molecular features we can get from multiple modalities of testing. So that includes immunohistochemical staining, FISH sequencing, hybridization, and developing a workflow to use the tissue carefully and to get an answer efficiently is something that we're continually trying to improve. And you've also seen that specific mutations now enable diffuse astrocytomas to be classified as a WHO grade 4. That includes the H3K27M mutation, EGFR amplification, gain of chromosome 7 with loss of chromosome 10, and TERT promoter mutation. And then in this last case, that not otherwise specified means that we were unable to complete all the testing that we would need to make a particular diagnosis. And a tumor that's called NEC, not elsewhere classified, is a tumor where we've completed the testing but still doesn't fit into a category.
So
that's,
in this last case, if you go back 3 slides or however many, you basically have greater than 95% chance that it's a grade 3 oligo. Because the papers were all under 5% for GBMs. So it seems to me that, that's not certainty, but greater than 95% is pretty, it's pretty good for pathology.
it's,
No, and I don't intend that, it's a derogatory remark. I mean, that's pretty good.
so I think 95% is the threshold where pathologists feel very uncomfortable. We're not happy at a 5% error rate, and that's part of why.
Surgeons are. I think this is in defense of both the neuropathologist and the assistant landscape. I think this is complex. And I think, improperly make the decision of hurt the patient, take the patient, make the hemorrhage. And on the other hand, patients, again, this is religion. This is like the Bible to them. Do I have a deletion? Do I have an IDH wild type? And they look at it as cure, not cure. And that's not exactly true. But we're going to be pressured more and more as the molecular diagnosis is to get, it's going to change how we do neurosurgery because we're going to have to get more tissue right now, because this isn't PCR where you get 5 cells and it becomes 50 cells. This is a totally different ballgame now. Families come very sophisticated, looking for the genetic markers that will make a difference in their life. And so it's going to change what we do as neurosurgeons. So this is a helpful case. It's a very educational case.
So it's a wonderful conference. the information that you have here is not part of the new WHO book, right?
This information has been coming out in 2018 via paper, so it's newer than the WHO.
So this, thank you very much for being here. This was a great conference. We have to do more of it because it really elevates us in terms of getting us to think in the molecular diagnosis, which is now in the future. Without further, so thank you very much. By putting the slides over as well. Two things. Next week, everybody have a happy